Bismillahirrahmanirrahim. Our lecture's topic is hand examination and X-ray. First, I would like to introduce myself. My name is Xray Muhammad Abu Futuh, a professor of plastic, burn, and maxillofacial surgery. The hand is a specialized organ responsible for many unique functions. These functions are touch, precision handling, power grip, pinch, expression. The expression might be by writing, signaling, shaking hands, or even caressing. The hand structure is complicated. Its surface area represents about 1% of the total body surface area, while containing many structures. These structures are 27 bones, 33 muscles, 2 main arteries and their veins, and 3 nerves. The crowdedness of these structures will make the manipulation during hand surgery difficult. This might cause iatrogenic injury during the surgical management of the hand problems. That's why we need magnification. The magnification might be in the form of loupe or even microscope during replantation of parts. The dedicated hand surgeon is a member of the hand management team, working together with the specialized hand therapist and cooperative and motivated patient. So we need to do a patient interview to confirm his understanding of the course of the management and his cooperation as well. The hand examination will start with history taking as usual. But there are critical points regarding the history must be covered for proper diagnosis and management plan. In personal history, patient's age may indicate the possible etiology. A baby patient may indicate congenital anomaly. A middle-aged one may indicate trauma. An elderly patient may indicate a sequelae of chronic disease. The patient's age will also affect the prognosis of the management as well. Regarding the occupation and the job expectation, it definitely will affect the management plan. An amputated finger in a pianist or surgeon will need micro replantation followed by several months of physiotherapy to preserve the precision handling required for their jobs. While a butcher may prefer a simple shortening and direct closure to return to work in weeks. In the same context, we must do everything in our power to treat the dominant hand more than the other helper hand. This will denote the importance of knowing the hand dominance of the patient. Regarding history of present illness in cases of trauma, informations about the circumstances of injury and the mechanism of injury are important. Circumstances of injury, like the scene of injury, is it clean or dirty, the causative tool, machinery, knives, glass, falling heavy objects, burns, and the mechanism of injury, we mean is it the injury might be penetrating, cutting, incisional, abrasion, crushing, avulsion, degloving, pressure sore, or other mechanisms of injury. For the past history, we have to cover any previous injury, previous operation, any medication taken by the patient, or the presence or absence of chronic illness. And the family history as well, because we have some abnormalities which run in families like camptodactyly and skeletal dysplasia. General examination includes the vital signs, any systemic abnormality, and any related abnormality. During the intrauterine life, the cardiovascular system and urinary system develop at the same time during hand development. So associated abnormalities of these systems might associate with congenital hand anomaly. On the other hand, there are some many congenital syndromes having hand anomaly. Like in the photo, this is a case of Apert syndrome. Apert syndrome is a craniosynostosis, means premature closure of the cranial sutures. Associated with syndactyly, this is the finger fusion. The local examination will be done in the order of inspection or look and compare, palpation or feel, examination of movement, that means by at the same time the examination of muscle and the nerve supply and the bony skeleton. And we have some tests to measure some measurements related to the hand function, and we have also a special test related to hand examination. To start with the inspection, the hand at rest has a special attitude, what is called normal hand cascade, as shown in the upper diagram, in which all fingers are flexed in all joints, and the flexion will increase gradually from index to little. And the longitudinal axis of the fingers while flexion pointing to the scaphoid bone, while the thumb is adducted with its palmar surface facing other fingers. In the down photo, the one to the right shows the index finger is out of normal cascade. It's extended with cut wound in the palmar aspect of its middle phalanx. So most probably it is a flexor tendon injury. Inspection must include the dorsal and palmar aspects of the hand. On detecting any abnormality, it has to be confirmed by comparing with the other normal hand as a reference. On inspection, we examine the color, the presence or absence of any swelling, deformity, wounds, presence of wounds, scar, or symmetry. The diagram on the left shows a swelling on the dorsal aspect of the wrist. It is called ganglion. It is the most common swelling in the hand. It is a cystic swelling along a tendon or opposite to a joint, filled with synovial fluid. It could be dorsal or palmar. It could be painful or painless. It might disappear by its own or might need a surgery. The photo to the right shows a hand with thinner atrophy in comparison to a normal thinner bulk in the adjacent hand. Palpation is done by manually taking the patient's hand between the examiner's hand and to start feeling or palpation from proximal to distal, eliciting any abnormality and commenting on the pulse, temperature, presence or absence of any nodules, any joint abnormality. Normally we have some nodules along the dorsal aspect of the hand in elderly patients, while the rheumatoid arthritis patients have a pathological nodules in the same places. Examination of hand vascularity is vital. First, we have to know the blood supply of the hand, which is through two main arteries, the ulnar artery and radial artery. There is also cross-vascularization between them through palmar arches, the superficial and deep palmar arch as shown in the diagram. This cross-vascularity enables vascularization of the whole hand by one of the main arteries. But unfortunately, 10% of normal population has no palmar arches. Normal vascularity can be examined or elicited by normal pulse volume and presence of capillary refill in less than 2 seconds and absence of signs of ischemia. The signs of ischemia are pain, pallor, pulselessness, paralysis, and paresthesias. Now, we have to talk about the modified Allen's test. Allen's test is a test to assess the radial and ulnar patency in addition to palmar arches patency. How this test is done? We ask the patient to clench fists. Then we compress the radial and ulnar arteries with thumbs and elevate the hand until we notice that the whole hand is pale or planched. Then we ask the patient to open the fist and we start by releasing the pressure on one of the arteries, the radial or ulnar artery. Planching should case in the whole hand in less than 5 seconds. This is the normal finding. Denoting patent artery, we are examining in this step either the radial or ulnar, and the patency of the palmar arches because cross-vascularization happens. Then we repeat the test, releasing the pressure on the other artery, and the planching should case in the same manner in the whole hand in less than 5 seconds. The down photos show two different patients. The photo to the left shows a normal Allen's test or modified Allen test because the whole hand is nourished while releasing the pressure from the ulnar artery. That denotes patent ulnar artery and patent palmar arches as well. And it is expected if we repeated the test and releasing the pressure from the radial and keeping the pressure on the ulnar, the same result will show. But the photos in the middle and to the right shows abnormality of the test. The photo in the middle, on releasing the pressure from the ulnar artery, we found that vascularization of the ulnar half of the hand takes place. And the photo to the right shows that on releasing the pressure from the radial artery, only the radial half of the hand nourished. So the explanation of this result is that the palmar arches are not patent and there is no cross-vascularization between ulnar and radial arteries. This might be normal. As we said before, there is 10% of the normal population has absent palmar arches, or abnormal if there is a previous trauma affecting the arches. Now, examination of the muscles. We have 33 muscles in the hand, 18 intrinsic and 15 extrinsic. Intrinsic muscles means the origin and the insertion are inside the hand, while extrinsic muscles, these are the muscles having their origin outside the hand in the forearm and getting the insertion inside the hand. The examination of movement, better to be examined as an active and passive movement with and against gravity, without and against resistance. Starting with the wrist joint, the photo to the left examining flexion of the wrist, and that one on the right examining extension of the wrist joint. Examination of the thumb movement from left to right, the thumb abduction, thumb adduction, extension, flexion, and opposition. Now, finger extension. The photo to the left examining the whole finger together, and to the right isolating the index finger extension examination. Now the flexion examination. To the left, the photo to the left examining the flexion of the proximal interphalangeal joint, while to the right examining the flexion at the distal interphalangeal joint, and this examination is against resistance. Now examination of finger abduction to the left and adduction to the right, performed by dorsal and palmar interossei respectively. Now, measurements in hand function. We can measure the range of motion, the pinch power, and the grip power. The range of motion can be examined by the goniometer, illustrated by the photo to the left, the pinch power by the pinch gauge, and the grip power by the dynamometer. Now, examination of innervation. As we know, we have three nerves supplying the hand: the median, radial, and ulnar nerve. And for the innervation, we have sensory and motor innervation. The upper half of this diagram shows the distribution of sensory innervation of the three nerves. The median nerve supplies the palmar aspect of the radial 3.5 fingers. The ulnar nerve supplies the dorsal and palmar aspects of the ulnar 1.5 fingers, while the radial nerve supplies the dorsal aspect of the radial 3.5 fingers, sparing the most distal part, which are supplied by the median nerve. The sensory innervation can be examined using the cotton wool, a tip of paper clip, 2-point discrimination using a pin, or a vibrating fork. The most classic way to examine the sensory innervation is a 2-point discrimination. Normally, we can feel the 2 points as 2 points with a minimum distance of 2 millimeters at the most distal part of the palmar aspect of the fingers. The lower half of the diagram shows the motor testing of the three nerves. The radial nerve can be examined through the finger extension and the interphalangeal joint of the thumb extension. And the median nerve can be examined through the fingers flexion, and the ulnar nerve can be examined through the fingers abduction. If we have a anterior interosseous nerve dysfunction or palsy, this is a branch of the median nerve which supply the flexor pollicis longus and flexor digitorum profundus. If we have palsy of this nerve and we ask the patient to do an OK sign, he will do a trick by extending the interphalangeal joint of the thumb and extending the distal interphalangeal joint of the index finger, trying to do an OK sign. This is the abnormal OK sign, denoting the anterior interosseous nerve dysfunction, a branch of the median nerve. Again, we can detect the ulnar nerve palsy through the Fromen's sign. We can ask the patient to hold a paper between his thumb and index by doing adduction of the thumb, which is supplied through the adductor pollicis muscle supplied by the ulnar nerve. Normally, he can do that if he has a normal ulnar nerve. If the patient has the ulnar nerve palsy, he will trick the movement and can hold the paper through doing a flexion of the flexor pollicis longus muscle, which is supplied by the median nerve. In that case, this will be considered a positive Fromen sign, and the patient have ulnar nerve palsy. Tenor sign, this is a test to examine nerve entrapment, as in carpal tunnel syndrome. If we do a percussion on the course of the median nerve below the carpal, in the carpal tunnel, below the flexor carpal ligament, this will lead to a sense of tingling along the course of the nerve. This result will be marked as positive tenor sign and denoting compression of the median nerve in the carpal tunnel. And now we reach it in local examination, the examination of bones and joints. This diagram shows a normal arrangement of hand bones and different joints. If we have an injury to the bone or dislocation of a joint, the normal hand cascade will be disrupted. The affected finger, the bony axis of a finger, or the joint or circumarticular structures will result in what is called scissoring or overlapping of the affected fingers, giving rise to abnormal hand cascade. We reach the hand X-ray as a very important investigation in hand management. The the different positions or views of the hand X-ray are posterior, oblique, and lateral. Posterior is a must if we are asking a hand X-ray. Then it has to be associated with another view, either oblique or lateral. The lateral, we do the lateral if we have one digit or one finger affected, and we can ask the patient to flex the other fingers to show the finger, affected finger upright alone. But if we have more than one finger affected, it's better to take an oblique view to see each finger separately in a clear way. Here, this X-ray shows that we have abnormality not detected except in certain view. So it's better to ask for more than a view that can detect the abnormality clearly. Here, these two X-rays will show the difference between the dead lateral and the oblique. The dead lateral to the right, only used if we have one finger affection and we can exclude the other fingers. But if we have more than finger affection, or we need to see more than one finger, so the oblique view will be the one suitable for the diagnosis. These are 4 X-rays, 1 and 2 preoperative, showing fracture of the proximal phalanx of the ring finger. 1 is the PA view, 2 is an oblique view, 3 and 4 post-operatively after fixation using 2 screws. This another X-ray showing pre and post fracture of the metacarpal bone of the thumb and 1 year post-operative fixation using plate and screws. This is an X-ray showing the neck fracture of the fifth metacarpal bone, what is called the boxer's hand. It's a common fracture in boxers. This is a fourth X-ray view, which is the stress view. This view is asked for or done when we are expecting a collateral ligament rupture. This is the ulnar collateral ligament rupture in the metacarpophalangeal joint of the thumb. This is what is called the goalkeeper hand. This is a common injury in goalkeepers when they fall on the ground with an extended thumb. And it is not obvious in the normal X-ray with no stress application. If we suspected this injury, we have to do stress on the metacarpophalangeal joint by radial dislocation of the metacarpophalangeal joint of the thumb, and the abnormal distance shown in the X-ray denoting the rupture of the ulnar collateral ligament. This is another X-ray showing to the left and right, showing the rheumatoid hand. The right one with fracture of the distal phalanx of the index finger fixated by what is called Kirchner wire. Another X-ray showing swellings. It is osteolytic swellings, multiple osteolytic swellings of the hand and even the forearm bones. Now we reached a diagnosis after examination and investigations. The diagnostic sentence must include etiology, pathology, and anatomy. How's that? We have a photo with the middle finger out of cascade, extended, able to flex, and we have a cut wound in the palm opposite to the middle finger. So this is most probably a flexor tendon injury resulting from incising wound. So if we have a diagnostic sentence, will be post-traumatic. This is the etiology. Flexor tendon injury. This is the pathology of the right or left middle finger. This is the anatomy. Now, the splinting is very important in hand management. We have many types of splintage. If we are planning to put the hand in splinting for a long time, and we need, of course, to avoid the fibrosis of the joints, because the immobilization of joints for a long time may end with fibrosis of the joints and limitation of movement later on. So we have to put the hand in safe position. Safe position will provide the circumarticular structures of all joints to be maximally stretched. So it be in the longest possible dimension. These positions are found to be at the wrist to be 20-degree extension, metacarpophalangeal joint to be 60 to 70 flexion, and the interphalangeal joint, the proximal and distal, in the 0 position. So this is a safe position we are using in the long-standing splinting, especially in burned hand and in some trauma patients. If we have a tendon injury, and we have to refer, we are not a hand surgeon, and we have to refer the patient to the hand surgeon. Before that, you have to put the patient in a static splint in a position according to the tendon injured. If we have a flexor tendon injury, better to put all the joints in flexion, like the photo to the left. And if it is extensor tendon injury, put the whole joints in extension, like the photo to the right. The idea of this is to prevent the proximal migration of the stump, the proximal stump of the tendon, because the tendon, after cutting the tendon, we have a distal stump and proximal stump. The proximal stump is still connected to its muscle belly, and it is exposed to proximal migration. To prevent this proximal migration and facilitate the repair for the surgeon, it's better to put the joints in this position. These are other types of splintage used post-operatively after tendon repairs, and we have a plan for the physiotherapy according to the type of splint. Replantation. We have messages about replantation for any general practitioner before referring the patient to the hand. If we have a patient with amputated parts, as a general practitioner, we have to do the following. First, we have to stop the bleeding, if any bleeding, of the hand, and do a light dressing. Then the amputated parts has to be cleaned roughly and dried very well, not to be wet. Then we put it in a sealed bag, and this sealed bag will be put in a bag with ice or cold water. This will provide what is called cold ischemia, and refer the patient to the nearest center having the facilities of microscopic replantation. I need all of you to know some of the common congenital anomalies. The syndactyly, the upper to the left, is the fusion of fingers. This is one of the most common congenital anomaly of the hand. And polydactyly, it is an axis finger. If it is to the lateral or ulnar side, it is called post-axial polydactyly. If it is to the radial side, it is called pre-axial polydactyly. It could be a complete finger or a part of a finger, maybe related to the adjacent finger in a joint, or more than a joint. And the lower photo, it is the camptodactyly. It is a flexion deformity of the finger joints. most commonly in the little and could be bilateral. It has a familial predisposition. This is the end of the lecture. I hope it was informative and well illustrated. Thank you.